Okay, all right, all right. So this is our weekly psych coaching call. So this is the coaching call that I do with my NP students. So this is what I'm just getting online to do, and yeah, right now we're just waiting to start the call. But yeah, once we start the call, we should be good to go. So literally just waiting for that to start. It's going to be starting at 8 p.m. So 8 p.m. Eastern Standard Time. So right now we're just waiting. But yeah, I'm excited. I think it's going to be a good one, as they always are. So uh, yeah, hopefully you have been well. Hey, Mike, sure, good to see you. Good to see you. And yeah, I think the weekend went pretty well. Let's see. What did we do over the weekend? Played a lot of Marvel Rivals. That's what we did. It was a more of a relaxing weekend, just catching up on live stuff. Had lunch with some friends, so that was good. Yes, sometimes I don't know about you. Sometimes I have weekends where I like want to be hyper productive and just work, but then I have other weekends that I just want to chill and do absolutely nothing. So this is one of those weekends. Is what it is. Sometimes I feel guilty about like not working that much to other weekends, but then other times I'm like, whatever, like it's fine. So it goes either way. Are generic psychotropics equivalent to brand name? So good question. For the overall, the most part they are. The main problem that I've seen has been with stimulants. That's where it's been the most problem with generics versus brand names. Yeah, usually if people are on a low dose of risperidone, it depends on what you think a low dose is. But if it's a low dose, it's usually okay to stop. But if it's a higher dose, that's when you can run into problems. Awesome. Hey, Jessica, I think you're on mute.
Okay, that should be better.
Yeah, okay, I can hear you. Awesome, good to see you.
Good to see you too. Thank
Yeah.
you.
Let me stop the recording here. I'll start it once we all officially get in. So
Okay.
yeah. How have you been?
I've been good. We had a little bit of a chaotic last month with summer camps and the like. So I was getting up at like 4:30, which I usually get up at 4:45 ish, 5 in the morning, but kind of like crashing out around 8. So, but things are well,
Yeah.
But I said I cannot miss any more Q&As because I've had the opportunity to come to one, and it was just so beneficial, and I just went to work the next day feeling much better and took your advice, and things worked out really well, and just to have that support and like feedback, and I'm like, even if I have to get up at 4:45 tomorrow to do my burpees in the morning and be a little tired, it is well worth it. And the summer camp schedule has lightened up a little bit now.
Yeah.
So yeah.
Why do you have to get up at 4:30 in the morning? That's so early.
Well, I have a routine, and I have been on a fitness journey for about 15 years.
Got you. Okay.
So, like, it's part of my process that I devote about an hour in the morning to like do my fitness outside, and then I do stretching and stuff, and then I get myself ready and then get the house ready. So it's a whole morning process, but it's very vital to like my wellness. So it's been 15 years of doing that religiously,
Got you. That makes complete sense. Yeah.
Mm-hmm.
Back when I was in residency, I started doing 5 a.m. workouts as well too. Yeah.
It helps, right? I find it very helpful.
Yeah, especially because no one's there. You can just put in your headphones and then really just like get started.
Yep. So I actually
Yeah.
have like a whole area now in the garage, and I have a pretty decent setup, and I do a lot of like CrossFit stuff out there and cardio, and then I mix it up, and yeah, and then I also like get a chance to have a little meditation outside in the morning, which is really nice, and it just sets the tone
Yes.
for the day.
Yeah. You go about it much better, and like you feel good and everything.
Yes.
Yeah.
Yes. So, but yeah, things are good. How are things on your end?
Yeah, pretty good. I just added in a couple new modules as well, so I'll share that.
Oh,
Yeah, I'll
awesome.
share that in the call as well too. And I've been meeting with some of the medical science liaisons or the MSLs
Okay.
to give us lectures. So we got Spravato coming up tomorrow, and then
Oh, good.
I just spoke with the Avelity person, and so we have that coming up in a couple weeks too. So I'll be making those announcements too.
That's awesome. That's going to be really helpful for me too, and
Yeah,
getting to have some like more detailed information about some of the meds that are not like part of my everyday toolbox.
exactly.
Increase my comfort level with it, which
Yeah.
will be really helpful. Yeah.
Yeah, no, of course, and it helps me too because it's like I don't use a lot of those meds either, the newer ones like Avality and things. So it's good for me to get a refresher as well.
Yeah.
Yeah.
Well, that sounds great.
Yeah.
I'm excited for that. Yeah.
Yeah, so we got that coming up. Yeah, other than that, not too much.
Well, good. Hopefully, you've been able to enjoy some of the summer so far.
Yeah.
Yeah, we actually, so the area in West Virginia that we're in is called Falling Waters.
Okay.
And so our neighbor up on the top of the hill, they had the legit fireworks, like fireworks that you would see in a city.
Oh, wow. Okay.
The nephew goes out to PA, and it's $8,000 worth of fireworks that he bought. He had a huge discount. My neighbor told me maybe $1,500. He walked away with so many discounts. They were so close that it rained down the byproducts of the fireworks.
Yeah.
And we had like this much in the bottom of the pool of all of the cars, but they were awesome.
Oh my gosh.
Awesome. Yeah.
That's a crazy amount of fireworks too. You said $8,000.
It was $8,000, and my niece has, she's autistic, and the loud sounds do bother her and my dog,
Yeah.
but she stayed in the house with him, and they hung out for the hour, which was really good.
Nice. So they got to enjoy
Yeah.
it. Yeah.
Yeah.
Yeah. That's awesome. So
Yeah.
okay, perfect. Looks like people are coming in. Hey Lavita, hey Dawn, good to see you. Let me share my screen here. Okay, perfect. Y'all can see my screen? Okay, I think, yeah.
I
So,
can see it.
okay, perfect. So yeah, why don't we get started here, and then people, I'm sure, will start trickling in. Okay, perfect. Looks like we're recording, so we should be good to go. So, okay, why don't we go in, we'll go in order, but if anyone is here already, so it looks like Lavita's here, so we could start with your question as well. So, you mentioned Relexi here, offers in-between doses that Concerta does not formulate. Yeah, so have you used Relexi before? Or like, did you get a presentation on it? Just curious.
Yeah, it's been around for a while. I want to say for like a year at least that I've known it, or longer.
Okay.
So I've used it for a few patients that wanted like the in-between dosing that Concerta doesn't offer. But they were long-term Concerta patients, so they were used to the Concerta and they didn't really like the formulation though.
Interesting. Okay, because when I was doing my research on it, it looks pretty much exactly the same as Concerta, so that's why I was curious.
I just think the patients were sensitive. You know how you have those sensitive patients with like brand and generic?
Yes.
So I don't think it's 100% the same, which is why it's also a different name.
I see.
So I think that's what it was.
Okay.
But it's a good option to have.
Yeah. Why don't we go through it real briefly? So pretty much Relexi methylphenidate, it's a similar to Concerta, so long-acting methylphenidate. It even has the same doses. The only thing, so that's what Levita was mentioning, is this one, this 45 milligram dose. So normally Concerta, you got to hop between 36 to 54. Why? I have no idea why that happened, but it is what it is. And so that's how they advertise, at least, is that, oh, you can use Relexi to get that in between dosage. But I mean, other than that, like the half-life is pretty similar. I mean, dosing is pretty similar as well. Everything else is similar, like a stimulant lasts about 12-ish hours. So other than that, so it sounds like it's more, from your experiences, unique patient experiences than anything else.
Yeah, I was gonna say I do have a pediatric patient on Concerta, but he has a dye allergy. I don't remember if it was red or blue dye. So we can't do the 54, but he needed that. So we do 2 doses of the other to equal the 54.
Oh, the 2 of the 27s. Yeah. Yeah.
I think it is 54. I don't know. I have to look up the particulars.
Oh, okay.
Of his dosing. But we do like 2 different doses of Concerta to equal 1 because he can't do the higher dose one.
Got it. And that's something I've done too to get to the 45. Like using Concerta, I've combined 18 and 27. So, I mean, like that's an option too. Or you could look at Relexi. How do you find with coverage? How does that work for you? Are you the patient's able to get coverage?
Yeah, I don't have an issue with that. I use a specialty pharmacy, and I know at least where I live, there's a pharmacy in particular that it's guaranteed like the $50 copay. So I just send it to that one pharmacy.
Wow.
So I think when it comes to neuromeds, it's really useful to talk to the reps because they've had other providers prescribe and they could give you feedback as to, hey, you use this one pharmacy. So you don't have to go through the whole trial and error of sending it to another pharmacy that's not going to have it, especially with these newer ones or any compound ones.
Yeah.
So it saves you time and frustration, and also the patient's more compliant, because if you send it to a regular pharmacy and they don't have it, then it's going to put the patient off and then you're back to square one again.
Exactly. Yeah. So that's a good tip too. So talking to the reps are local, so you got to talk to the local reps. That's the key, because everyone is so different, or every area is so different.
Yeah, exactly. And not just that, they have a lot of great resources too.
Yeah.
Like I put up on the resources some ADHD booklets from Calgary. I was actually talking to a rep today for Austedo, and he was sharing with us that they allow him to give up to 7 books a year. So he had a list of books that he could give providers, and they just use your NPI, and they can provide it to you within, I think he said like 2 weeks or so.
Oh, wow.
And he had a few options on there. He had Stahl's psychopharmacology, the one with the patho. He had, I would say, at least like 8 different books. And I know like my Stahl's psychopharmacology book, I got that from a Caplyta rep. So they are definitely useful and have a lot of great resources, I would say.
So that's
where I've learned a lot of like the tips and tricks. I'm going to post also a paper I have for anybody practicing in Texas. So it's a copy of a bill. So what you do is you quote that bill and you say that the patient is doing well on the current med, that's a brand name, and that it would really be deterrent to affect the patient's mental health if you switched. So you quote that bill, and I tell my MA staff, I send them the quote and the phrase to put on the PA. And we have no issues. We get the PA approved the first time around.
Oh, wow. That's incredible. Okay. So pretty much you get them started on the med.
I will add that for you all for Texas.
Yeah. So I think that's another good tip too. You can start the med, use the copay card or whatever resource they have, and then to continue it, that's what you're saying, is for use the PA and then put that language in there that the patient's mental health will deteriorate if they come off this med.
Yeah, because I know with PAs, they can be a pain. And I think a lot of the times they have like a protocol to just automatically deny you
Mm-hmm.
the first time,
They do, yeah.
thinking you're going to give up. And
Right.
I've gone to some dinners where some doctors have said that they had to write like a whole long letter saying that if they denied it and the patient committed suicide, it would be on them, basically.
Mm-hmm.
So that saves you that whole hassle and time and effort.
Exactly. Yeah, that's really smart. Yeah. Anything else you wanted to discuss regarding Relexi? Okay. So Richard.
I'm good on my end.
Okay, awesome. Richard, I just saw that you have entered, so welcome, welcome. Okay, and then you had mentioned about, is there any way that we can report drug-seeking behaviors from an outpatient setting, E-Force, for example? Yeah, good question. So I'm not aware, and I looked this, I'm not aware of reporting for just drug-seeking behavior. Now you can report if there's illegal activity happening, like let's say they are diverting the medication, let's say they're selling it, or there's some kind of street stuff that's going on, then it is possible. Then you can refer to local law enforcement, to DA. But just for seeking, I'm not really aware of any way to report that. But I think we should look at it a little bit deeper too. So, like, if a patient is seeking a medication, usually that tells us that there's something underlying going on, because the patient, they just don't want to be on the meds, right? So if it's underlying ADHD, if there's an addiction issue, then it might be a better approach to pursue rehab or some kind of treatment with that, rather than looking at it from like reporting it perspective. Of course, you make your clinical judgment on how you want to treat the patient, whether you want to keep seeing them or you say that you can't see them anymore. But yeah, I think switching that lens from trying to report them to trying to see how we can help the patient seems to be the more like better thing that we can do for them. Yeah,
That makes sense.
yeah, and any thoughts or comments, questions on that?
No, I think it is appropriate. I do agree with you. It's important to look at it in a therapeutic manner. The reason why I asked this question in particular is because of very specific drug-seeking behaviors and a few of the things that would make it impossible for me to continue the patient-provider relationship. But I would love to explore that avenue. However, in private practice, it may be a little difficult.
Yeah, exactly. And I know it's frustrating too, because these patients can be very frustrating for us to work with, because they're the ones that really test our patients. They're the ones that we're very hesitant to see. And I know I shared the case of that one patient I had to fire because he was just ADHD seeking, or stimulant seeking, hopping around different provider to provider, got banned from a pharmacy. So it's definitely a headache dealing with these patients too. But I think just having a level of empathy for them at least helps me stay grounded. Yeah. Anything else on that?
No.
Okay. Awesome. And then I know you had a second question here as well. So you said, can we discuss adverse childhood event trauma index? How do we assess it? How do we measure it? What are the 10 categories to count? So good question. So here, let me pull something up real quick. So I uploaded a new module. So it's under this section, the miscellaneous psychiatry, and then here under trauma. So I uploaded one on ACE scores. I thought it was a great suggestion. And the main thing that I've used in clinical practice is the ACE questionnaire. And basically this goes through 10 different questions about childhood neglect and childhood trauma. And this was very eye-opening for me when I was a resident, because I had just sort of a general understanding of that, okay, childhood trauma affects mental health, but then I was not aware of the whole ACE study that was done. And so if you're not aware about the ACE study that was done, basically it was a Kaiser study, and ACE stands for Adverse Childhood Experiences, and it's looking at these 10 categories. So abuse, emotional, physical, sexual, neglect, emotional, physical, household dysfunction, substance use, parental separation, mental illness, incarcerated household member, domestic violence against mother or caregiver. And this is a topic that you can definitely screen at your intake. Like, you can just give them the questionnaire or just ask them if you suspect there's a trauma component going on, because it affects everything down the line, especially as an adult. It affects all these mental health parts. And what really stood out to me was that it also affects physical things as well. So yeah, because they had found kids who had these traumas, they would come in with recurrent asthma and obesity and binge eating, and they were trying to figure out, okay, why is this happening? Why are these kids having these such significant problems, or why are these adults having such significant problems? And they traced it all back to the ACEs, because it can impact. Because if you think about it, too much cortisol is very damaging, and it's a stress hormone. But too much causes damage. Just like too much norepinephrine, it's stimulatory and it helps us. But if you have too much, then that can be bad too. So these ACEs, all the cortisol, all the stress, all the inflammation, that can cause damage to the amygdala, the hippocampus, the prefrontal cortex. And so that's why when we see a BPD patient who has emotional dysregulation, or it's hard for them to make good executive decisions, a lot of it can be, or the fear, the amygdala, where they might get way easier triggered compared to the average person. So then looking at it from this lens has really helped me to empathize with the patient as well, just because they tend to be more difficult patients too.
Yeah, wonderful document. Thank you for putting that together. My follow-up question is, I can see how this assessment can help to provide patient-centered psychotherapy, but how would it guide prescription practice?
Yeah, good question. So one thing is that if you perceive it from a trauma lens, then I think you can help validate the patient's experience. So that's one thing, is that you can deepen your relationship with them. So now imagine if you have a patient coming in and they have these dysfunctional behaviors, these patterns, but they're not really sure why. They might feel like they were quote unquote born this way. Then having that can help you validate their experience. So compassion, not blame. And then because now you can validate their experience, they feel closer to you. So now that they feel closer to you, they feel more trusting than you, then any kind of treatment you give, SSRI or antipsychotic, mood stabilizer, whatever you do, they're a lot more likely to follow through with, or a lot more likely to start it and follow through with it, because now they trust you. And I think that's more important than any sort of like technical or scientific thing. Because if the patient trusts you and the patient believes in you, then they'll stick with you for the long haul.
Okay. Yeah. It strengthens therapeutic allegiance.
Yes, so strength is therapeutic allegiance, and then of course it also allows you to screen for PTSD as well.
Okay. My next question is, how young would it be appropriate to run this exam?
Probably around teenage time.
Teenage time?
Yeah, teenage time, because then they definitely start to have good frontal lobe function, and then they can also start to appreciate how some of their the experiences they've had, or they are currently having. So, like, I'll share a case with you. So I was doing inpatient psych, and I had this 13-year-old patient come in, and so she had issues, or I forget why she came in. She was in the inpatient unit, but what had happened was that she wasn't really opening up to the staff, and so it was hard to work with her. And then one night, she told one of the staff members that her mom's boyfriend was coming in at night and touching her inappropriately. And so when that happened, of course, so I'd come in the next day, and then I found out this all happened, and then CPS had been called, and so like they were at the scene, and then mom was being investigated. But I think the saddest part was that the mom did not believe the patient that the boyfriend was doing that. So point being, I mean, obviously tragic, sad case, but point being is that, like, a patient like that, like, she can definitely process a lot, and she can understand that, okay, these things are going to affect her.
Mm. It's unfortunately not the first time I hear of this kind of case in which the aggressor is present and the one of the guardians either chooses to not take action or just overall pretends not to acknowledge the issue. I think it's a defense mechanism, primitive one, but a defense
Yes.
mechanism nevertheless.
It is, and also on the mom's perspective too, because you think about it, the mom feels guilty for now letting her child get affected by now this person she is in love with. So now she's kind of conflicted between those two parts. So she feels guilty about that, but she might not be able to confront that guilt. So denial is one of the first defense mechanisms that we all have. It's an immature defense mechanism, but people have that. So a lot of people respond that way. Yeah, there's also this book too. So it's called The Deepest Well. Basically, this is the book that I read in residency that really goes into the ACE study and the ACE scores in great detail. So I think this is a pediatrician who wrote this, but she talks all about all the way that like how the ACE study was developed and how they figured all this out, the whole story behind it, and then what to do about it. Yeah, so she was delivering the care to vulnerable children. So she started realizing a lot of this stuff.
Great resource, thank you.
Yeah. Anything else on that? Okay.
Yeah, I just agree with you. Like working with folks in the recovery center, the things that they've shared over their childhood experiences, I mean, it definitely is a resounding pattern that I've seen. Is just the trauma in childhood, and then they start to uncover it and start to remember things. And some of them walk in remembering them, but yeah, a lot of sexual trauma, a lot of emotional trauma.
Yeah. And then if you look at it further here, some of the criteria, let me pull it up. So if you look at it, some of the criteria is not stuff that you might think of. For example, did you live with anyone who went to jail or prison? So that isn't something that you normally would think to ask, but it can be very detrimental to the kid. Or did someone ever swear at you, insult you, put you down? Like a lot of people might think that just normal, so they might not perceive it as trauma, quote unquote. Or this one where they didn't have enough to eat or had to wear dirty clothes. So this isn't overt trauma inflicted on them. This is more lack of love, which is still harmful, but it's in a different way. Yeah. Does that make sense?
And it's also a reflection of the socioeconomic status.
Yeah. Yes. But it doesn't have to be. This happens in all socioeconomic statuses.
Good point.
Yeah. Anything else on that?
Can I add, there's a really great book. It's by Father Greg Boyle. He's a Jesuit priest, but he started Homeboy Industries. And basically they've done work all over the world with people in gangs. Greg Boyle, yeah. And it's called Tattoos on the Heart. And basically it's so much of it is the adverse childhood events of these gang members who essentially, they're in a gang. They're jumped into gangs when they're very young, and then drug problems, all of these ACE problems at home.
Yeah.
And but basically by Homeboy Industries gives them jobs. And what they've found is by giving them jobs and meaning and community and family, that their lives changed immensely. But I didn't grow up with a lot of that kind of stuff or any sort of awareness of what was happening, and it really helped me to change my views and add a lot of compassion to people, and it's a really easy read as well.
Yeah.
So
Yeah, that's a great suggestion. Thank you.
Mm-hmm.
Yeah, I had a similar realization when I was doing my prison psychiatry stuff as well too. A lot of them came in very young, very early, and a lot of them had all these ACE scores too. So yeah, it's the line can be very thin sometimes.
Yeah.
Yeah. Okay, so Amanda says, how to appropriately document when an adolescent's demonstrating borderline traits. I know no official diagnosis over 18, but the traits are there. Document as a rule out. Yeah, so Levita says document traits, assess, add sentence, rule out. You can treat with meds, amygdala. Yes, so I agree with that wholeheartedly. So you can just say something like the patient has. Here, I'll just copy paste it. Like something like that. Basically, that they have some characteristics of BPD, and so you can just say that. You don't have to necessarily give them the overt diagnosis to still give the treatment, as long as you keep it in the back of your head that that's what you're helping addressing. You start DBT or whatever you're doing. But I will push back. I tend to be a little bit more liberal in diagnosing it than the traditional, like that they say that you can't do it under 18. I do it sometimes if the case is obvious or severe, because I don't want to limit the patient from getting help, because a lot of providers will go in the opposite direction where they don't want to label it. They'll say, okay, I don't want to give a personality disorder diagnosis to anyone. But then the problem they run into is that the patient might be getting treated for anxiety, depression, unspecified, when in reality, if they had known what the more closer problem was, the more accurate problem, then they could get better treatment rather than kind of just running around the system giving the runaround. And I've also found the diagnosis, people have responded well. Like, I haven't run into people who've just kind of lost their marbles over it. Like, I think people want to be validated and they want to understand what's happening. So if you're able to deliver that in a compassionate manner and in a supportive manner where you also indicate, okay, this is how we're going to treat it, then I don't think you'll get much pushback if you feel like the diagnosis is warranted. Yeah. Any thoughts or anything on that? Okay.
Have you seen in practice too that the majority of folks with personality disorders have multiple personality disorders, dual diagnoses, or triple?
Yeah, so that's why it's called cluster B, because like they tend to run together. If you think about it, it tends to be a dysfunction of trauma, of neurobiological issue, of errors, those or genetics. Like those would be the couple things. So remember that personality disorder diagnoses are just like different symptoms that are laid out that we say, this makes up their part of their personality. That's the whole thought process behind it. So if someone has one brain health problem, they likely have another brain health problem too. Just like if you get some heart problem, you might have congestive heart failure, but you might also have a heart attack down the line. You might also have arrhythmias, and they're all stemming from the problem with the heart.
Okay.
Does that make sense?
It does, yeah, because I have seen several in practice. The more I'm learning about, trying to really keep my eyes open for the personality disorder diagnosis, they do overlap, many of them. So
exactly. At the end of the day, it's just a label that helps clinicians to understand the patients better. Like that's pretty much all it is, and to help us guide treatment. So, like for example, if you tell me that hey, this patient has BPD or something, then I'm like, okay, that I would consider a different form of treatment than I would if they just tell me they have anxiety or depression.
Okay.
Yeah. Does that make sense?
Yes. Yeah. Thank you.
Yeah, this is a good topic to explore too. So thanks for bringing that up. Okay, so we did that. Okay, so Madison says she has a 40-year-old female, 18 weeks pregnant, high-risk pregnancy, IVF. So she's taking 2 blood thinners, the aspirin and the Lovenox. So she's on buspirone, having depression, no SI. Doesn't want her on SSRI due to bleeding risk. Yeah, so definite good questions. So Madison, are you here?
Yes, I am.
Okay, awesome. Anything else we should know about this patient?
No, I mean, she's just like she said her anxiety's under control. It's just the depression. Like she said, she cries every day. She had to actually quit her job because she's just not doing, isn't finding enjoyment in anything. And so on my end, obviously, I know the risks of not treating that in pregnancy, but
I feel like I'm kind of in a hard position because she has maternal fetal medicine working with her and her regular OBGYN working with her. So I don't, I've been trying to coordinate with them, just other options, but especially just with her being more high risk, that's where I'm a little bit nervous, and just a standard pregnancy, I wouldn't be as, nervous about it, but just with her the other risk factors going on, I just don't really know.
Yeah. So how strongly does the patient want treatment?
She would like to start an SSRI.
She would. Okay.
Yes, it's the her OBGYN told her that she doesn't really feel comfortable with her being on it.
I see.
Because of she's on aspirin and Lovenox.
Yeah.
Started by maternal fetal medicine for whatever reason, for blood clots or whatever else, but
right.
But she's like, I will like do anything. I mean, she feels so miserable.
Got you. So couple thoughts there. So one is that the patient autonomy is in my opinion, that's the number one thing. So if the patient really wants to do it, and because the OB-GYN is offering their suggestion, which are definitely valid, don't get me wrong, definitely valid things, but if the patient says, hey, I understand the risk and I feel that the benefit's going to be worth it, then it's something that you can still advocate for, and she could still advocate for too. And you can document, just have the understanding that you discuss that risk. It's not like a guaranteed, and the patient agrees to that. So I mean, that's one. You can also do Wellbutrin, for example, to help with the depression. You could do mirtazapine, so that's less serotonergic than an SSRI. Wellbutrin is less, it's not serotonergic. They tend to be less used in pregnancy, but it's not like there's a contraindication to use them. So in this case, the contraindication of the SSRI outweighs using the Wellbutrin or the mirtazapine. So I mean, those are good options if you want more natural stuff. Omega-3s, saffron, those are good ones too, and those tend to be a lot more innocuous. She might not notice as much benefit, of course, but they can definitely be good starting options for the depressive side of things.
And we have TMS in our clinic, and you can do TMS in pregnancy. So I've been debating. I was maybe going to talk to her OBGYN about that, but yeah, I know because I was reading about Wellbutrin, and I guess I don't know why. I mean, it would be a good option for her. I don't know if I have just this preconceived notion that it's not, don't prescribe it in pregnancy or what, but
yeah.
But yeah, from what I was reading too, yeah, they said it was a decent option for her. It's hard when, it's hard when I don't have the background with, especially with, high risk pregnancies and things like that of, okay, how much of a risk are we actually taking? I mean, I know, if I had a patient who wasn't pregnant on, aspirin, I would still start them on an SSRI, but then now with pregnancy, it's just so hard to know how much it increases that risk.
Exactly. And that's why they come to see us too, because we're the providers, and so we're the experts here, and so we can make those nuanced clinical decisions that no other provider is going to know, and no other textbook is going to know too. Like, this is the real life kind of case where you're not going to find that answer pretty much anywhere. So you have to use your own clinical judgment, which gets better as you seek these cases and then as you make these difficult decisions. Yeah, so that's another thing. Another thing is blood work too. Just making sure that at least she's topped off blood work wise, no nutritional deficiencies. I mean, I don't know her diet situation or lifestyle situation. What's the reason she's high risk? So it could be that there could be some nutritional component that's contributing.
Yeah, I think she has PCOS.
Yeah.
So yeah.
So that another thing could be clean lifestyle, clean diet, exercising. I mean, I understand she's pregnant, but like just making sure her diet is as clean as much as possible, as much as she wants to do, right? Reducing the amount of inflammation that she has, and that's only going to help the baby. The cleaner diet she eats, the better the baby's health is going to be. And then that in turn will help her brain health too.
Definitely.
Yeah. So that stands out, and also therapy. Like that's
I know. I
Yeah.
talked to her about. She was very against it in this last appointment. I brought that up again, and she's like, at this point, I would do anything. So hopefully she'll. I'm like, just during your pregnancy, you don't have to continue it, but at least it's something, non-medication. If so we'll see. Hopefully she does. But
Exactly, and plenty of. I mean, it's a trying time for any mom, so there's no shame in doing it either. Yeah.
definitely.
So, but yeah, I think
Awesome.
it's what the patient ultimately wants to do, because if she has capacity and she's able to make those decisions for herself, and we're the guides along the way to help her. Yeah. Anything else
that
on?
makes sense.
Yeah. Anything else on her?
No, I don't think so. Thank
Okay. Yeah. Okay. Then you had this, and then you had this other case. So,
Yeah.
ADHD, 37-year-old, AFib, sleep apnea, obesity, BP was 150/97. Okay, tried Wellbutrin and Prestige. Has a cardiologist. Yeah, taking lisinopril, testosterone. Okay, so what are your thoughts right now on this patient?
Yeah. Well, so I see him tomorrow, and I just kind of wanted to be prepared. If he asks about stimulants, because he just got the official diagnosis. His primary had him do neuropsych testing.
Yeah.
So, I mean, I was reading kind of back at some of the notes, and he did well on Wellbutrin in the past, and his AFib is stable. And he's not taking he's taking lisinopril, but he's not, on any long-term meds for his AFib. I feel like I don't know, again, with like the risk, obviously you would talk with them about that. But I know, like, we've just in previous meetings and everything, with stimulants could potentially still be okay for him. I don't know. Is it something mainly to just talk with the cardiologist first before you make a decision? Or, because with, the arrhythmia, that's kind of the part that scares me with starting like stimulants or Wellbutrin or.
Yeah. So yeah, couple things on that. It sounds like the arrhythmia is not a current issue; it was a past issue. Right. So that's the thing. And stimulants can increase blood pressure. There's no doubt about it too. But we can still mitigate it and manage it. So, for example, the patient's on lisinopril right now, and so maybe that could be optimized a little bit more. So, I don't know the dose of that. Cardiology. What is your gut telling you? Do you want to wait till they get involved, like till you can speak with them, or you want to like treat the patient now and then touch base with them after?
I guess typically I usually contact them first before I kind of tell the patient, like, I'll touch base with them, and then we can, talk. I give them a bunch of different options and then say I'll touch base with them. Too, with like when people have blood pressures like 150/97, is that ever something that prevents you, like that day, if they have that blood pressure, from starting a stimulant or like Wellbutrin? Or is that something, where you're kind of like, well, we'll just, continue to monitor it once we start it? Like, at what point would you say, no, we're not going to use those medications?
Yeah, good question. So it always comes down to benefits versus risk whenever we do any kind of intervention. So now here, the benefits we would have would be ADHD treatment, possibly some depression treatment. He's done well on it in the past, so it's likely that he'll respond. So those are the benefits he will get, and improvement in whatever problem he's having in his life. But then the cons could be that it might increase his blood pressure. That's what we're worried about. So, now that we have those, what will tip it is, okay, how bad is his life dysfunction? Like, is it so bad that, okay, he needs treatment ASAP, or else he's going to lose his job. He's going to lose his relationship. He's going to, his house is going to be gone, or whatever it is. Or if it's super mild, then, you might want to wait. So that's where, like, we have to weigh out the decision of, okay, where, how strongly do we want to push it, and how strongly does the patient want to push it?
Yeah, that makes sense. So typically, do you like in cases like this, do you coordinate with cardiology, or would it be something that, if they've been stable for a long time, they previously did well on Wellbutrin, that you would, have no problem just starting them back
Yeah.
up on it?
For me, I tend to be a little bit more liberal, so I would start it. And like if I was seeing, I'd be like, okay, I'm gonna start it, but I want to watch your blood pressure. I'm also gonna be talking to cardiology in the meantime to just find out other things that we can do to bring down your blood pressure.
Sure, that makes sense.
Yeah, because if that's the only problem, then because I do want to help out the patient and speed up things as well.
Mm-hmm.
And then, but also another thing I want to talk about was his lifestyle stuff. So if he has ADHD, I mean, he's got sleep apnea, so it means he's not sleeping well. He's not getting good oxygen at night. He's being tired during the day. So
Yep.
of course that's going to contribute to focusing and attention, all of that.
Mm-hmm.
So like
Definitely.
how open, exploring how open he is to that type of natural intervention too, losing weight. Because if he loses weight, his sleep apnea is gonna get better, and if his sleep apnea gets better, then his blood pressure is gonna get better too.
Mm-hmm. And he's taking that tirzepatide. I'm not sure how long he's been on that, but hopefully,
Yeah.
I think currently I think he's like 370,
Oh wow. Okay.
370 pounds. So I think it hasn't been too long he's been on that, but I think he is trying. So that's good to make some lifestyle changes. But
Yeah, and then the additional benefit of the Wellbutrin is that it will help his appetite, or reduce his appetite, so it can aid him in the
Yeah.
weight loss journey.
yeah, that's a good point too.
Yeah, if you're exploring other options, for example, especially if he's more the hyperactive type, then clonidine and guanfacine could be used as options, the extended release version, and then there you'd also get the dual benefit of helping out his blood pressure.
Yep.
So that could be an option to start with to consider too. And like, so for example, you could start with that and then go to the Wellbutrin, or if you want definitely something more stimulating, you start with the Wellbutrin, and then down the line you could consider that as well too. Like for example, say at bedtime, then at bedtime it might also help him fall asleep too.
Mm-hmm. Yeah, that makes sense. I have a
Yeah.
quick question going back. You mentioned earlier about the norepinephrine. I guess I had a patient who is on the max doses of atomoxetine and Pristiq. So is there like when you're on? I mean, is there with the norepinephrine? Like, is there like a limit? With that you need to be watching. Is it more so just watching for any like adverse, like if it's too stimulating? Because with serotonin we have serotonin syndrome. Is there something similar with norepinephrine? Like I was thinking about that other day that you brought that up earlier, so I was just curious.
Yeah, good question. So it's always tracking it based on the patient's response. So their blood pressure, their heart rate, how stimulated they feel, how wired they feel. If you think about it, any kind of syndrome, right? So it's all a spectrum. So if you look at, for example, diabetes, we say that A1C of 5.7 to I think 6.2 is pre-diabetic, and then after that's diabetic, and then before that's non-diabetic. Well, those are just numbers along a continuum. And it's like at X point, 6.2 is when we decide it's not diabetes to diabetes.
Mm-hmm.
So it's kind of like with serotonin syndrome. It's like, if it exceeds X amount of threshold, then it becomes that syndrome. But let's say someone doesn't fully meet the criteria for serotonin syndrome, but they're still experiencing symptoms of it.
Mm-hmm.
So you might say that, hey, just because they don't have serotonin syndrome, okay, they're fine, but not really. They're still having symptoms. So you might need to decrease the serotonin load that they have.
Mm-hmm.
So it's all a continuum.
Similar. So those are kind of the big things with the norepinephrine. Then you just watch for if they're on both of those meds on higher doses.
Exactly.
Just see how they're tolerating it. Yeah. Okay.
Exactly.
That makes sense.
It's like some patients might feel great on 5 to 10 milligrams of Adderall, and then others might need 60 to 90.
Sure.
Yeah. Anything else?
That makes sense. Thank you.
Yeah. Anything else on that?
No, thank you.
Okay. And so then what the other thing with this patient, so again, you can do nutritional labs as well, at least making sure nutrition wise he's good, checking magnesium, zinc, Yeah, those are the top two. I mean, he's getting testosterone supplement as well too.
Mhm.
So that tells me that he's probably not producing enough exogenous testosterone. So is there some kind of zinc deficiency or something that's contributing to that?
Yeah, that's a good point too.
Yeah. And also, if you do start a stimulant, then long acting tends to be better than short acting, just because it spreads out the blood pressure. Uh, but here's another thing that if, let's say, the patient only needs help certain amounts of time, then you could just use a stimulant if you're using a PRN, because then you're not
Mhm.
getting that continuous exposure like Wellbutrin. Then you're just getting PRN use, which could be better for him long term for blood pressure wise, rather than like something like Wellbutrin.
Yeah.
Yeah.
Yeah, that's a good point too.
Yeah. So a lot
Awesome.
of options to explore there.
Thank you.
Yeah. Okay, so moving on. So Pallavi says, so have several patients report increased sweating. Yes, the night sweats, generalized hyperhidrosis. Yeah, have you felt anything effective to help with this? Yeah. So really good question. So let me share something here too. So I started a new section called side effect management, and so added one on sweating and SSRIs. So definitely check that out. But the main thing I want to cover here, so at least med wise, we tend to use anticholinergics. So benztropine. So I've used this before, especially if the patient is also on an antipsychotic. Then I've used this to help with the sweating. I've used this one as well, the glycopyrrolate. Also, I just give it at bedtime, so I've used that one. Clonidine. Clonidine can be helpful too, and I like clonidine a lot because if the patient, let's say they have anxiety and they also have trouble sleeping, then you can give the clonidine, propranolol as well too, to especially decrease some of the physical arousal symptoms. So a lot of time the sweating could be from too much norepinephrine activity. I know we discussed just SSRIs, but SNRIs are notorious for it too, because not only are you getting the serotonin, but you're also getting norepinephrine. And if you think about you're running away from a bear, then you need to be sweating so you can cool it, because you're going to heat up, so you got to cool down your body. But that's why there's increased sweating with SNRIs. And so something like propranolol can help decrease a lot of that physical aspect of it as well. Oxybutynin can be used, but then it's got some bladder stuff as well, so it wouldn't probably be the ideal choice unless there's something else that you're treating, or like let's say the patient has a urologist and you would say, hey, maybe we could use oxybutynin to help with that. So those would be the things, at least med-wise. Obviously, you want to try to reduce the dose if you can. So it's not always dose dependent, but sometimes it can be. So if you can reduce the dose for sweating, that can help. For example, I had this patient who was on 60 milligrams of duloxetine, and he was on it for a few months, and he said that he was doing well. But then he started telling me that he was experiencing sweating in the morning, like he would just wake up drenched, and he didn't correlate it with the duloxetine at all, so he never mentioned it. But he said it was bothering him, and it coincided with the time that we had increased it. And so when we dropped it down to 40 milligrams, his sweating went away. So so decreasing dose can help as well too. Obviously, just checking for other things, the medical stuff, some supplements that can be helpful. So basically, these are more the calming ones. So magnesium, L-theanine, ashwagandha, B complex, sage too. I've mostly used these ones. I've used these three: ashwagandha, L-theanine, and magnesium, just to help the patient's overall sleep and just overall calming down a lot of the activity that's happening. So basically, you can just kind of take a step-by-step approach to make sure that you're addressing the patient's needs, especially with the sweating. And then lifestyle things, of course, to start with, like cooling and like using cool, like nice soft sheets, moisture wicking clothes and moisture wicking sheets, reducing stress at night because anxiety could exacerbate it, that type of thing. Yeah. Any questions on that?
I just actually saw a client today at the group house that has side effect of sweating with lamotrigine. I had bipolar disorder type 2, and was actually doing very well on the lamotrigine 100 BID.
Yeah.
And we have paralleled it now to the increased dose. He's down to 50 once a day. The depression is back. I saw him today. He really wants he wants to titrate it back. I just increased to 25 in the PM dose.
Uh-huh.
And could I also, because he's obviously on a very fixed income, state insurance, very limited resources. He's
Yeah.
also on Concerta, but the sweating didn't parallel with the Concerta. It was happening before, so we have pinpointed it to the Lamictal. Just wondering, have you seen this? Have you seen the same in practice with the Lamictal side effect, and would you also maybe utilize some of these strategies for him?
Yeah, I'd utilize similar strategies for sure. So with Lamictal, it's one of those that it like the sweating is not really listed as a big side effect. For example, I had this patient who he said he had memory loss with Lamictal, 25 milligrams, so starting out. And this is a guy who is kind of built like a tank, and he tolerates very high doses of other medications. But he said the Lamictal just caused brain fog and memory concerns that went away when the Lamictal was gone. So it can happen with Lamictal, but yeah, because similar strategies, right? Because at the end of the day, you're just trying to decrease the amount of serotonin overload and the amount of, if there's any kind of stimulatory thing that is happening. I mean, this is all complex, and these medications, they, let's say they have mood, for example, Lamictal is a mood stabilizer, so stabilizes the neuronal membrane, the calcium channels, or the sodium channels, but they all have peripheral effects too. That's just the main one, and then they all do random stuff in the brain, all these meds do. So that's how I at least conceptualize the side effects in my head.
Okay, that makes sense. Thank you. Yeah, I told him we would just take it slow, and I want to get him some relief with the depression, because it was very helpful in the past. So
right,
take it kind of slow with the dose adjustments and see how he does.
Exactly. Yeah, I think that makes sense to me.
Okay. Thank you.
Yeah, no problem. Okay, so then Misty here, so this is a question she posted. So recommendations for patients in choosing between inpatient, partial hospitalization, and IOP. How to suggest or choose programs, and what might they expect of each. So yeah, so think of it like a hierarchy. This is especially done in the child and adolescent world. So for example, let's say a kid comes into the inpatient unit, and they come in for significant SI, they maybe had a plan, and then sometimes the kid will just get discharged from inpatient to outpatient, which is, it happens, but then other times they'll go through a step-down approach. So they'll start inpatient, then they'll go to partial hospitalization, then they might go to IOP, and then they might go to just regular outpatient. And so the difference, so inpatient, they're there in the hospital every day, 24/7. Usually the stay is 7 days, give or take, sometimes more, sometimes less. And so these are the patients who you think that they are going to be a risk to themselves or a danger if they don't come to the hospital immediately, or there's some kind of psychosis or something that puts the patient at risk or someone else at risk. Then you have partial hospitalization, where they come in for pretty much during the day, and they leave at the end of the day. So for example, the adolescent partial hospitalization I did rotations at, the parents would drop in the patient around 9 a.m., would come back around 4. They'd be in a session, they'd be around with other kids, and so during the whole day they would have therapy sessions, and maybe like a med check, but mostly it was different therapies. There's group therapy, there's individual therapy, there was skills building classes. They would do high school coursework as well too. So it was always kind of so that's a little bit step down there. And then you have IOP, which is just purely outpatient. So they might have a couple sessions a week, for example, for IOP. And then of course you have regular outpatient, which is one session every couple weeks or month or whatever. And so what you're trying to do is you're trying to risk stratify the patient on suggesting or choosing a program. So if you think they're a super danger to themselves and need to go in, or else there might be a problem, inpatient. If you think that they might be a danger, or they might have some SI, but the family can keep them safe, but it could teeter on anywhere, then you maybe look at partial. And then, especially if the family's saying, yeah, we can keep the patient at safe, home safe, then IOP might be like, okay, they have some SI, but there's no plans, but it's definitely affecting their functioning, and they may or may not be going to school. Then you could look at IOP, and then, of course, standard outpatient follows. So there's no like criteria like, okay, this is inpatient, this is partial, this is IOP. It's more trying to risk stratify the patient and determine what is the least obstructive type of care that will still get them benefit. Because these are obstructive. For example, partial is, the family has to drive the patient every day to the place. The patient's going to be taken out of school if they need to, so it's definitely obstructive to them. Whereas the IOP might just be a couple times a week, so it's less obstructive. So you're trying to just balance out the need of the patient with what the family wants, what the patient wants, especially if let's say if it's an adult patient, what the adult patient wants. That's what you're trying to do. Any
Great.
questions? Yeah. Any questions? Yeah.
Oh, sorry. I was just going to add to that. So if a patient is, like say they're needing a lot of skill building at the same time,
Mm-hmm.
like fine tuning on medication, but maybe not technically a risk.
Right.
And they could do partial hospitalization or IOP.
Yeah.
Is that like still a reasonable choice?
Yes, it is, because now you're saying that they need a higher level of service. That's what you're saying with the skill building. You're saying that they need more services that the current level can provide. So if you feel that, okay, for example, I had this patient, 14, 15-year-old, the same BPD type of symptoms, like maybe diagnosis, maybe not, but they definitely had it. And I was considering, I was in my residency, and so I was considering inpatient hospitalization because the patient was saying a lot of SI statements. But then my attending saw the case, and they were like, yeah, but like I don't think this patient's really going to do anything. Then we talked to the mom. The mom's like, yeah, I don't think they're going to do anything. But they were very dysfunctional. They had a lot of maladaptive coping mechanisms. Like this was a patient who was taking photos of their meds and posting them online saying, hey, my Abilify got increased, woohoo. So definitely had some skills problems, and so we decided the family wanted to prioritize that at a high level. So that's where we said, okay, why don't we do partial hospitalization for that patient? But that same patient easily could, but they started in outpatient. So now let's say if the family was like, hey, we think the kid's fine, we don't want to really do anything, we want to continue with it, then they could have stayed outpatient or done an IOP. So it's like you're trying to balance those various factors to put the patient the best place they can.
Perfect. Thank you so much.
Yeah, of course. Okay, so then Michelle had a question. So 44-year-old male, GAD, ADHD, failed a whole bunch of meds due to side effects, so Lexapro, Zoloft, Paxil, Effexor, Doxepin, Buspar, melatonin, amlodipine. So immediately just reading this, my first question is always, okay, so when a patient says they failed, like I want to find out why. So how long did they try the medication? What dose did they try it for? How severe were the side effects? Because like let's say, because they referred to you a while back, so let's say the person before didn't tell them that, hey, you might have some side effects for the first 1 or 2 weeks. Then they might have just gotten a side effect, like a headache, 1 or 2 times, and then quit. And so now it looks like that Zoloft is a failure, even though they may have only taken it for 4 or 5 days. And then now we run into this problem where now a new provider, for example, now Michelle, is seeing this patient, and she's like, what do I do? The patient's saying they failed all this. So that's where getting that history really makes a difference. And if you find out that, okay, they didn't really have a good trial on it, they didn't stick with it long enough, that's what makes me think, okay, maybe we need to go back. So it's just important to get that, just consider that foundation wise. So then you said, right, so he seems never satisfied, there should be a pill to fix everything. So that what that tells me is that there's probably a problem with patient expectation. So this patient probably has the expectation that, okay, I'm just going to take something like an antibiotic or like a Tylenol. Like, you take the Tylenol and your pain gets better. So I suspect that this is what the expectation of the patient is, which is not accurate. So I think psychoeducation would go a long way here for this patient. So that's the first thing. So it mentions Adderall as well, feeling less creatively silly and jovial, affecting interaction with family. So yeah, that's the thing with ADHD meds. Some patients do say that, and that's where balancing that the pros and cons of the medication and the dose. So maybe if he goes down to 10 milligrams, that may be better, because you're always trying to balance the benefits while limiting the risks here. So those are two thoughts I have just going through that. In terms of other options, so if you want other options, Trintellix or Vibrid, so those tend to have less side effects, I've found, just because they tend to be more serotonin modulating. So rather than just increasing serotonin right off the bat, they tend to be more they target specific serotonin receptors. So that can actually limit the amount of serotonin flooding that happens. And so that can help with the side effects as well. So that could be a consideration. If they've already tried a bunch of SSRIs, then you could consider a TCA. Of course, the problem is that you might have additional side effects with that, because that one tends to be more side effect notorious. Mirtazapine could be considered as well, so that is an option. Supplements. So if you want to pursue the more natural, holistic route, doing supplements, saffron, omega-3, L-theanine, magnesium, especially because it seems like there's a lot of anxiety, N-acetylcysteine, right, the GAD, OCD picture. So that could be an option too if you want something milder like supplements, but you kind of want to get their buy-in. So you could start with supplements and then go to medications. But then the downside with supplements is that this patient says he never feels satisfied and wants a pill to fix everything. So I think starting with the psychoeducation is going to be the most important piece in this case by far. Yeah, any questions, concerns on that? Okay, perfect. Okay, so Aaron says, we discussed an inherited 35-year-old patient, history of hypothyroidism, autism. Oh yes, yeah. So complex patient. So 1 milligram Xanax BID, 4 milligrams lorazepam BID, Depakote. So pretty hefty meds, right? So I think the first thing to remember with this is a tough case in and of itself. Like, you're probably not going to get perfect results with this case. So with all the comorbidities here, this serious med regimen, so that tells me that patient's having quite a bit of debilitation. So maybe just the first thing would be mentally to adjusting our expectations and adjusting the patient's expectations on how much treatment and resolution is possible. Not to be discouraging at all, but it's like if someone comes in with stage 4 cancer, there's only so much that treatment can do. Now, we still want to do the most that we can for this patient. So my first question would be, also, are you here, Aaron, by the way? Okay. So my first question would be, okay, what is our target here? Because when we see this kind of patient, there's so much going on. There's self-injurious behavior, right? The hitting, drinking water, irritability, sleep problems, agoraphobia stuff. So it looks like there's a whole bunch of stuff going on. So the first question would be, okay, what is it that we want to target? So you mentioned about next steps. So you mentioned naltrexone, thorazine, switching antipsychotics. So let's start with the switching antipsychotics. So it sounds like you increased the risperidone and it helped. So you're getting some good benefit on the risperidone. So it may not be the ideal thing to switch that because you're already getting benefit. So you know that you're getting some benefit. And if you switch, then you could really destabilize the patient. Of course, like, people do it, and if there's a good reason to do it, then you can. But it sounds like it is helping. So the Depakote was increased by 250. So what would be the Depakote level? That would be my question now, because maybe, this is a big dose just looking at the numbers, but if this guy's very tolerant of meds, then maybe his levels is not a high enough level for him, or he's metabolizing quickly. So checking that Depakote level, I think, will be helpful as well. You mentioned naltrexone. So low-dose naltrexone is used for aggression as well, so you can use that. Helps decrease inflammation. Basically, just start at 0.5 milligrams, and then you titrate up to 4. You have to use a specialty pharmacy for the low dose naltrexone, so you can do that. You also mentioned this sleeping problem, so sleep disruption and sleep onset difficulties. So trazodone or mirtazapine could be helpful for this patient as well. If he gets better sleep, then they will probably have less self-injurious behavior, less headbanging and stuff too. And SSRI. So if a lot of this is caused by anxiety, for example, we see can't leave the home. So I'm wondering, is this due to his aggressive behavior, or is this due to anxiety related? So that's a consideration too. So maybe, I know you tried the escitalopram, so maybe a different option could be helpful. And it's always so hard to say. For example, you say that it caused increased aggression and irritability. Well, did it really cause the increased aggression and irritability, or was there just already the underlying aggression and irritability that was not fully treated yet when you tried the escitalopram? So I think that's an important distinction to figure out as well. NAC caused GI side effects. That is common with the NAC. Sometimes you have to start at a low dose. I would just wonder what dose was started, because sometimes, like usually, I like to start at 600, but maybe you need to start at 300, for example, if there are GI side effects with NAC. Amantadine, that's an option that can be added on as well with this patient, because it looks like they're not on that, so that could be added on. When I look at this clonidine 0.1 TID, so what I'm wondering is happening is, are they having a lot of ups and downs? Like they take the clonidine and they feel chill for a while, but then it goes up, and then they go down, then goes up, then goes down. So I wonder if the extended release clonidine, if that would be better than the clonidine plus, than the TID dosing one. So consideration there. And then I also see the Xanax BID, lorazepam BID. So that's two benzos here as well too. So I wonder if he's also having this like kind of up and down, and if a longer acting one with a short-term PRN might be a better approach. Like for example, clonazepam, just twice a day, that's done, and then having a Xanax or Klonopin or an Ativan or a Xanax is needed for the aggressive tendencies. That could be helpful as well too, just to get more stability. Lamotrigine could be used as a mood stabilizer, so that's an option. You could use oxcarbazepine or trileptal, so that's an option as well too. I know that he has a GI doc, you said, just making sure his gut health is optimized. So if he's stooling well, like not constipated or diarrhea, because a lot of these patients with autism, intellectual disabilities, their gut health tends to be really out of whack, and doing fiber and probiotics can make a big difference for these patients. So that's a consideration. Supplements, of course, supplements could be helpful in the regimen. A lot of these patients might have nutritional deficiencies, so checking for that, checking for magnesium, omegas, zinc, because their diet, like for example, I assume this patient's diet is probably not the healthiest, so just making sure that that's good as well too. A keto diet can be very helpful. Keto diet has proven for epilepsy, a lot of evidence for bipolar disorder, a lot of mood stabilizing evidence. So if he's able to go on a keto diet, that could help a lot of his symptoms naturally as well too. Yeah, hope that's helpful. Any questions or concerns on that? Yeah, so I think the main thing is that, figuring out what direction you want to go in, because I just mentioned, like, you could go here, 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 here. So what we need to do is just figure out, okay, what is it that we want to really prioritize and focus on that, because that's the only way that you're going to be successful with these kind of patients, these really complex patients. Otherwise, a problem that people run into is that they will kind of go with the whim, like the patient will say, oh, I have this problem, and so they treat that, and then next visit they're like, oh, I have this problem, then they'll treat that, rather than staying the course and like looking at the long-term approach of the patient, rather than just kind of going by whatever immediate complaint that they have. Okay, so yeah, anything else on that? Okay, and then, all right, Stephanie, did you just upload this? I see just now, okay. Okay, so this is a big case. Oh
Yes. You to hear, and she's the reason why I signed up for this.
man, I see. So okay, why don't you summarize the case for us?
So I just met this patient about a week ago. She was a mobile crisis patient, and she reports history of PTSD, ADHD, opiate use disorder, reports having seizures because she hasn't been able to get somebody to prescribe her clonazepam because her previous psychiatrist retired over a year ago. But it's more like 2 years. She was working with the practice back in 2024, but the last time she was prescribed the clonazepam was August 2024. And when I asked her, okay, where have you been out of state or something, or how have you been getting the clonazepam? Because you should be done with withdrawals by this time. She said, well, it lasts years. Withdrawals last years. I educated her. She was so adamant that I didn't know what I was talking about. And then she denied getting clonazepam off the street. And wanted me to start her on clonazepam, but she was very hostile, very angry, and accusatory. And I'm like, I just met you, and she said the last place they basically terminated her care.
I see.
Because the PA did not know what he was doing and messed up her meds. That's what she was just like, everybody's messing up everything. And then with the seizures, she insists that I don't have any psych problems. I'm not on any medication. I'm not on methadone or Suboxone. I did it all on my own. I've been sober for 3.5 years. And the only thing that she can't get off is the clonazepam, but insists that she did not get it off the street.
I see.
But I just kept on trying to get more history. It was a little bit inconsistent. And then I did a quick urine drug screen, and she was positive for fentanyl, cocaine, THC, and then she was calm when she saw the urine results.
Right.
She was as calm as can be. And then she started crying, saying, "This is why I want someone to prescribe me the medication, so this won't happen."
Right.
And then I saw her on Thursday for a follow-up. She was even more angry at me, and basically I'm definitely gonna terminate her, but I have to talk to the chief medical officer. I'm in community health, so we see a lot of substance abuse, and it's my first time working in community health, and I've just never been disrespected like that before. And this is only our second appointment. And she wants clonazepam. I feel like she is drug seeking. She's not safe for me to care for. She refuses detox. She's insisting she's not on drugs.
Yes.
And that was just a fluke, the test results.
Right.
Refuses antipsychotics, mood stabilizers, Topamax, Depakote, but she claims seizures. So I'm like, okay, how about we do those options? She's like, no, it's because of the clonazepam. It's clonazepam withdrawals.
Right.
And then on Thursday, she admitted that, yes, she gets it off the street.
Right.
And that's why she's here, so she won't get it off the street anymore.
Right.
So I just wanted to know, basically saying that she's recording everything to sue me and everybody else. And I know she doesn't have a case, but it's just very scary. I'm still new to the field.
Yeah. Okay.
And I just don't want to get sued early on.
Yeah. Got you. So let's walk through all of that one at a time. So the first thing is, okay, I think your gut is telling you what you need to know. Like, you understand this patient's going to be a walking liability, and you're going to get in way more trouble down the line by taking on this patient than you would from terminating care right now. Right? So I think that you've already kind of understood that. So I think that's the first thing, because like this, if this patient's causing problems now, imagine down the line when, let's say, they miss a refill or they use more than they needed to, and now you're stuck. So you're stuck as the provider now, and then now let's say you start clonazepam with them 3 months down the line, they're like, hey, I want my double refill, and if I don't get that, then I'm going to go into withdrawal.
Right.
Now they've held the clonazepam hostage with you.
Right.
And so that's where it becomes a real concern. So I think it's good that you're recognizing, okay, this is a walking red flag here, and there's pretty much no benefit to you seeing this patient.
Right.
So that's the first thing, and then the second thing you mentioned was with getting sued. So it definitely, I think the fear of getting sued is just so blown. Like, it's in all providers' heads, even my head too. For example, I shared a case where I had terminated a patient a couple weeks ago, and even I had that fear of getting sued, even though the documentation, everything is on my side here. And so that's why when I have a lecture on discharging the patient. So I'll pull that up here. But one of the points that I make on that is that pretty much you want to do it in the most non-judgmental, nicest way possible. So that way the patient doesn't feel like they're being abandoned or whatever, but you're doing it for their level of care. So this one, I talked about 2 different patients who I've discharged. And so I had that fear for both of those patients as well. But remember, it's just a manipulation tactic. Like, this patient is not going to have the resources to sue you. They have no case to sue you. It's going to get thrown out. So it's not going to lead anywhere. And there's nothing wrong that you have done. Yeah, I know Annika says it tends to be very difficult to terminate care, right? And so that's the hard part you run in, because like the patients do need help. But
Right.
I think a good way to say it is that you're not able to provide them the care that they need. That's the way that I like to present it to the patient. So for example, I had this one patient, like the patient I cover here, so you can definitely watch that
Okay.
video. But the whole point was that the patient was ADHD, drug seeking, doing all this stuff. And so the way that I framed it to him, so I put together this discharge letter for him. And I pretty much, what I said, I said, I'm no longer the appropriate provider to safely and effectively manage your psychiatric treatment, acknowledging the time we worked together, the effort you made in pursuing your mental health care. And so the whole point was basically that, hey, I'm not able to provide you the service you need. Like, it's not that you're terrible or whatever, it's that I can't do it for you. And like, I'm not good enough. So you take all that blame, but then that way the patient, at least their ego's preserved. And then now they're much less likely to sue you, and they'll go on their way.
Okay. Thanks.
Yeah.
Yeah. She was very threatening towards me.
Precisely.
But I'm only seeing her like virtually from now on.
Well, I don't know if the virtual aspect of things is going to change things. Yeah, so, and then let me share with you, for example, this patient. This one, pretty much, she sent me some very nasty stuff where she couldn't get her meds filled on time. And so just sent incredibly nasty messages. Like, let me show you. They're the most... I've never had a patient talk to me in this way in my life. And so as soon as that had happened, I had said that, okay, I need to terminate this patient. Yeah, like this is the messages that she had sent me. Maybe 2-way Tuesday, are you going to rebush some cast? I'm sitting here effing waiting for them to pick up my medicine. Jesus effing Christ. Yeah, this is part of your job. They should be able to get in touch with, like, as soon as she sent me these messages, because she didn't get her script filled like a day, like after, like there was some problem and she couldn't get it filled immediately, and she had driven to the pharmacy 3 or 4 times to get it, even though I hadn't confirmed with her that it even sent it. So then she blamed me. But the whole point was that after I got this, I was like, okay, I need to discharge this patient ASAP. Like, this is not a patient I need to keep. And she was a very, very nice patient too at the beginning. But then I never, in my letter, I never said it as, hey, like that was extremely rude behavior, because again, I'm trying to preserve her ego. So I just said, due to logistical issues, coordinating your prescriptions across state lines, challenging verifying medications, believe your best interest to continue treatment with a local provider who can effectively manage your medication needs. So basically we just said, hey, it's a pharmacy thing, so that's why we're gonna terminate care. And I even give her a refund for a full recent appointment. And so even because I provide her services, but I was just like, you know what, like I want to give her no leg to stand on. So she has literally 0 case, and now she even got her money back. So yeah, pretty much just I took all the blame, but this way you can mitigate any risk. You can lower the risk of any kind of retaliation or suing as much as possible.
Okay. Thank you.
Yeah, I hope that was helpful.
Yes.
Yeah, don't worry, it happens to all of us. Anything else on that?
I just had to do that today with a
Yeah.
borderline patient that she basically went online and just bashed myself, bashed the owner of the practice, all caps, highly incompetent, doesn't know what they're doing, she doesn't care. I mean, very personal attacks, you know?
Yeah.
And the lady had also like really escalated in the office before with me, and I just, you know, I lowered the whole situation. I just told her, you know, I'm not going to meet you there. It's not going to be helpful to you. That, you know, I'm here to help you. But things had escalated the past couple visits. She wanted me to continue her Xanax, and the Xanax wasn't working. And she, according to the primary care, the owner of the practice, she's mad because he won't give her like long-term disability. So today I knew that it was going to be a situation because I had talked with the therapist in-house who's still seeing her, and I did almost verbatim what you are talking about. And I told her, I said, you are 100% right. I am not equipped enough to help with this situation. It actually pissed her off. And the therapist at the office, she said, Jess, I told you that this might piss her off. She went online and like called me a gaslighter. I'm a horrible person. And I'm like, but you know, at the end of the visit, she was just really wanting to yell at someone. And everything that you say, the person's probably going to shoot down or arguing. And at the end, I just said, look, what is it that I may do to help you for the rest of this time together that we have? And she said, I said, okay, I hope that you have a good part of your day, and please let me know what I can do to help connect you with another provider that's better equipped to serve you, to meet your goals that you're looking for and that you deserve.
Right.
It's a really hard conversation because the countertransference is huge.
Yeah, of course.
Yeah.
Yeah. You're it's the hardest thing, honestly. It's just like, no matter how the patient reacts, you have to be the one in calm control, and you can't let yourself get off course no matter what they say or do. Because then if the patient could do 20 wrong things, and the one wrong thing you do is what's going to come back at you.
Yes.
Yeah.
But then, you know, if you look at the actual like review on like, because I don't look at them, but the boss, he had told me about it. He said, just don't look at it because because I'm a very sensitive person anyway. He said, you're gonna really get upset. But if you look, and like, she didn't like edit it appropriately, so like she has all this bashing, and then it like the bottom of the whole comment, it's saying how wonderful that I am, how wonderful that Mark is, and I'm like, and he said, this is why I don't rebuttal, because the general public, I mean, we have like 4.9 stars.
Right.
And he said, you know, it gives you a little reality, but I feel genuinely sorry for this person because I do think she's repressing some very deep down trauma, and it's coming out in somatic different symptoms, and like it's just, she's lashing out, she's in a fight or flight response at all times. And then sometimes I think if you don't engage at that level, it almost pisses them off more in the beginning.
Exactly. Like you can definitely get so much deeper into, because if you think about it, that's the dynamic that they're used to. They're used to that arguing dynamic, whether they grew up with it, whether they're in the relationship with it. So they're used to that. And so when someone does that, like, that's their comfort. And it's almost a way for them to seek attention, to seek validation, at least because that way, at least, you know, someone's paying attention to them if they're yelling and screaming at them.
Yes.
So yeah, I think you approached it exactly how you could have.
Yeah, I'm able to stay calm for sure. In terms of the seizures, any other options or suggestions?
Yeah, so
Because I don't feel comfortable giving her the clonazepam.
yeah, of course. So I mean, one thing just before that, just remember this: it's an internet saying, right? Don't feed the troll. You're gonna have haters. You're gonna have people talking crap about you. But in any kind of argument, it takes two people to escalate an argument. So if one person's going like this, they can only go so far unless you rise with them, and that will allow them to rise up. But like if they go and start rising and you stay right here, like there's only so far they can go. So yeah, just don't feed them. Anyway.
I was gonna say something real quick. I was gonna say, I think it was a red flag at the beginning of the visit that the patient said that they had gotten fired by the other provider.
Yes.
And that the other provider was incompetent. I feel like that's a big red flag.
Right.
Also, when they specifically request a particular med, that's another flag. So there was quite a few flags there.
Mhm.
I was gonna say too, when there's a personality disorder, there's zero accountability. All they do is blame, and you're gonna find too that most of the visit they're just complaining,
Right.
instead of you like actually addressing symptoms or issues. And also, anytime you see a long email, that's another red flag for a personality disorder.
Right. Yeah. I agree with that. And then the other thing is that she probably just read about it online, that not taking your clonazepam causes seizure. So therefore, it's like, it's kind of like when the patient comes in and reads the DSM-5 criteria for bipolar or for POTS or something similar to this. So the seizures, if you suspect that they are just she's making it up, then that's fine. Then you just don't do anything. But if you think there's a chance that there might be actual seizures, then you just say, hey, I'm not equipped to treat seizures, but I could refer you to a neurologist to pursue that. There you go. And 99 chance out of 100, she doesn't do anything with that information.
As she was saying, she went to the ER, they did all types of tests. She's fine, it's just clonazepam. I'm like, well, I can give you Depakote or Topamax. I don't have a seizure disorder. What don't you understand? It's from the clonazepam. Just give me my medication.
Yeah.
Like, I'm sorry.
Yeah.
For your explosive disorder.
Yeah, definitely personality disorder there, but she will not accept it, poor insight
Right.
and accountability, like you said. Lack of it.
Right. And at the end of the day, patients are free to make, this is America, they're free to make their own
Right.
decisions.
Yeah, she said, I thought you were cared. You acted like you cared.
Yeah.
I do care. And this is why I'm not giving it to you.
Exactly.
Because this is not for your safety.
Yeah. Anything else on that patient? Okay. So you said this is a different patient, just to confirm. Second patient was very hostile.
No, it's her.
It's all the same patient.
Two visits. This is what she sent. Yeah, she sent to me in the last visit.
I see.
Yeah.
Okay.
Yeah.
Yeah.
It was intense.
So as you can see, like we all get these kind of messages.
Yes.
So yeah, you're definitely not alone in that. Yeah. Okay. Anything else on this, or any other questions we didn't cover?
I was gonna add another thing.
Yeah.
I wouldn't have invested all of my time and energy into writing that whole long post about her visits explicitly. The way I see it, it's just not worth your time. You're just letting it affect you and giving it more attention. So just discharge them and that's it. Let it be.
Yeah.
Yeah.
I would in a private practice. It's just in the community health center. They get grants from the government. It's just a whole lot of. We have some contracts with the jail people. So.
Oh yeah.
We manage to put them when they're on probation. It's just, but my chief medical officer is very she backs us up. I recently discharged someone who hung up on me and wanted Adderall. He was gonna buy it off the street. I'm like, okay, fine. She was just all for it. He called today to say he wants to schedule his appointment. She said he doesn't need to decline for us to discharge him. He was smoking, vaping in the office, and he was yelling at me and hung up on me and said he was gonna go elsewhere. So he's being discharged.
Right.
So as long as you're the first one to get the story to your supervisor, then you're good. So if you get the vibes that something's off with the patient, you could tell, or after the visit, report it straight to your supervising.
Okay, that's good.
Always get the dibs. And I understand the documentation, so I get it, and they have your back. So yes, I document as far as work, but I mean, outside of work, like for this, I wouldn't have wasted all my time and energy writing that long thing.
Okay.
Just a few sentences, get to the point, and that's it. Because it's going to affect you.
Yeah.
And don't let it affect you. That's what these people do. So as long as you give it your attention and your energy, they're picking up on that and those vibes even now.
Thank you.
Yeah, facts.
Good advice.
Yeah, awesome. Anything else on that, or anything we didn't cover?
I was gonna ask about your sister because I don't think I got to ask about the team. Unless you want to go off the record for that.
Oh, okay, yeah, sure. I'll do it. I'll do that off the record, sure.
I thought so.
Yeah. Okay, so I wanted to share a couple things with that. Give me 1 sec. So I added in a new section here. Hold on, let me share my screen again. So I added a new section on lab interpretation. So pretty much going through different lab panels. So this is like a core lab panel that you would do. This is a more of a nutritional stuff. So like these are all labs that I order: vitamin D, B12, iron, omega-3, magnesium, some hormonal stuff as well too. And then I'm going to be adding in more hormonal stuff and then infectious stuff. So just wanted to introduce you to this. So if you're wondering like what labs to order, if you're wondering about a specific lab, you can definitely come on there. And then I'm going to be breaking down my some integrative lab work that I do as well with patients, and I'll walk you through. Like for example, I have some patients who've had abnormal labs, so I'll walk through the interpretation of that. So
On the labs, I was gonna ask, I haven't looked at it yet, but do you have, for rolling out like anything autoimmune, like the specific labs? Cause I know I had to do it for a patient that felt like she wasn't validated by the PCP. So I just ordered whatever I thought was most appropriate. And because our documenting software, it got updated, so it's really weird and it only lets me order certain things. Like it doesn't let me order everything that I wanted to order.
yeah.
I was just wondering if you have autoimmune in there.
Yes. Yeah, so ANA, for example, I had a patient who had to work up for lupus, and so I was ordering a bunch of autoimmune stuff for her as well. So that's going to be on the list too. Autoimmune in terms of like Sjogren's, in terms of Hashimoto's, that's the common one. Sometimes rheumatoid arthritis, that's another common one as well. Because a lot of this stuff can overlap. Autoimmune in terms of those are the common ones. Yeah.
Thank you.
Yeah. Anything else? Anything we didn't cover? Okay, awesome. So I hope that this was helpful. So let me I'll cut the recording here. Oh, just remember, so tomorrow we're gonna have our Spravato talk. So they're coming in to speak with us. We can't record it, unfortunately, just due to their regulations. But so tomorrow we got that talk. It's at 8 o'clock Eastern Standard Time tomorrow. So one of the MSLs is going to be coming in and discussing that. So other than that, I hope this has been helpful. So let me stop recording here. And then okay, perfect. So we have stopped recording. Yeah, awesome. What were you asking? Something about sister?
Yeah, remember you had shared the news about